Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Pamela Buchanan. She's a family physician. Today's Kevin MD article is The ER Doctor Who Became the New PCP. Pamela, welcome back to the show.
Hi, Kevin. Thanks for having me.
All right, tell us what this latest article is about.
Well, it's about lived experience and what I've been seeing as of late. So I'm family medicine trained, but for the last, I think about 15 years, I've been working as an emergency room physician. And so I left family medicine, kind of the lifestyle with my children and needing to be home at certain periods of time and not wanting to take work home
Mhm.
because, all the excessive work with the EMR. But it's like I am the new PCP because by working in the emergency room, I see a lot of patients with primary care type problems. And I know this has always been true. I remember that from residency on, but it's becoming even more and more worse. So lets me know that a lot of primary cares are quitting and doing other things or decreasing access. So patients are left out, kind of out in the cold.
Now, when you say that there are some primary care issues that you're seeing in the emergency department, give some examples of some of these chronic conditions you're seeing.
Oh, well, you see, I mean, it's these chronic conditions are just about as American as apple pie. The bread and butter, diabetes, hypertension out of control. Of course, morbid obesity leading to a lot of other things like osteoarthritis, CHF not managed, and coronary heart disease. Those are a lot of things. And then from your run-of-the-mill stuff, sniffles, runny nose, vomiting, things
And
that
are
people used to see their primary care for.
and then are these people coming to the emergency department explicitly because of managing these chronic conditions, or are they coming with something acute and, oh, by the way, we have all these other chronic conditions that's being left untreated?
I get a lot of I can't find a PCP. I can't get into the PCP. I used to be on this blood pressure medicine. I need a refill.
Hmm.
And then the next month, again, over and over and over.
So what kind of options do you have in the emergency department if someone comes to you, say, for untreated blood pressure, or if they ran out of refills for their diabetes medication? What do you do?
You know, I used to ask that to administrate all the time because it's different. Each doctor does it differently. There are some doctors who, frankly, just don't treat hypertension in the ear. I have colleagues like that. And there are some who will give you just enough for a couple of weeks. And that's, I wonder if that's even helpful because they're not getting into a primary that quickly. So, generally speaking, it's up to the physician. My philosophy of practice is I actually still would get on the phone and try and see if there's a PCP in our area who might be able to fit this person in if they have the insurance. If they don't have insurance, then we're in a bad situation. But usually you're going to get anywhere from no medication to maybe 2 weeks to a month.
And when you get on these phone to try to arrange for follow-up primary care, in general, what are the wait times like? Are there even clinicians that accept new patients around your area?
A lot of closed panels, so a lot of physicians that don't have any capacity anymore. And then the wait times I've been seeing, that's the reason I wrote this article. The wait times I've been seeing are astronomical, somewhere around two. I heard of one that was a 6 month wait for primary care. It used to be this was the kind of wait you only had for specialists.
And the fact that these patients are coming to you for chronic conditions, diabetes, high cholesterol, high blood pressure, how does that affect the care that you could give to people who really need to be in the emergency department, or come to you in an urgent care setting? Are they waiting longer? So how does that affect your patient flow?
It's bad for everybody in general. And really at the core of why I wrote the article, because it does make the wait time in the ER that much longer. Because in the ER, you think it's for things that are, or a person is in imminent danger, where their life may hang in the balance or they need to be hospitalized. That's really what the ER is for. We have a saying in the ER, we say we treat them and street them. So,
Mhm.
so it's kind of a different feel when the ER doctor's treating you. They don't it's not what ER doctors do all the time. So they're not accustomed to managing and adjusting your thyroid medicine, your blood pressure medicine. They're just accustomed to getting you to the next point until you can see one who does this for a living. So yes, the wait times are longer, and it just lets me know that we need to support physicians. We cannot afford to lose any more.
So in a hypothetical scenario, let's say someone comes to you with high blood pressure and you prescribe, say, 1 month of a blood pressure medication and they cannot find a primary care doctor, do they end up just coming back to the emergency department after 1 month?
So the very thing I was trying to leave in being a primary care physician is the thing that I am doing now because there are patients that kind of think of me as their doctor. I
Mm.
was just on shift last night. I did it overnight, and yeah, there was a patient. And hey, doc, like I am their doc. I guess I am in some sense, and I know their history at this point. And yeah, they use the primary. That's why the ER has become the new primary care for people of low socioeconomic status, people who I see it a lot in people who have, say, busy jobs where they can't take the time off. Usually people who work, say, factory type jobs that are not forgiving when you take off.
Mm.
So we're just kind of in a situation that's not ideal and not good for prevention and long-term health management.
So, just to give us a sense of how prevalent this is, in a typical shift, approximately what percentage of the cases that you see are chronic condition related, primary care related?
And I'm not exaggerating. It's most of the things I see. Most of what I'm seeing in the ER is just management of chronic conditions in primary care. And probably a third of it are true emergencies and urgent conditions that need hospitalization or some procedure.
And is this simply a function of a lack of primary care clinicians? Is that purely the bottleneck? If your local hospitals and medical centers around the area simply increase access, would that solve most of the problems we're talking about today?
What I'm hearing from patients is a combination of the access has decreased sharply, especially since the pandemic. That I noticed that it wasn't as bad before the pandemic. It's always been an issue, but
Hmm.
it's worse now. And so there's less access. People don't have insurance and the cost. And a lot of times people are having issues with the cost of paying for medications. So I think it's the combination thereof. But I think one of the biggest problems is access.
And just for the patients who may be listening to you now, why is the emergency department not the ideal place to go for follow up and treatment of chronic conditions?
Well, because emergency room physicians are more accustomed and better at treating acute care conditions, and chronic conditions are not what they do regularly. And they cannot follow you on a longitudinal basis and manage it effectively. We can't do labs, we can't adjust, and so it's just completely unideal. And eventually, it becomes a legalistic issue for emergency room physicians, and sometimes it gets to the point where a lot of doctors choose not to continue to prescribe the chronic care medications because they can't be responsible for managing the disease process.
So isn't it a legal liability too if someone comes in with high blood pressure and if there's an
It
emergency
is.
physician who chooses not to treat their blood pressure or put them on a blood pressure medication and discharges them, isn't that a potential malpractice risk as well?
It is. And a lot of our physicians will treat while they're there and give you a follow-up, a slip, tell you to follow up here, but not give a prescription because, as you know, they're not going to give you a prescription for 6 months.
Hmm. How long has this been going on for? You said that this was an issue even before the pandemic, acutely worsened
I,
after the pandemic. It sounds like this has been
I,
going on for years now.
I don't remember a time it wasn't going on because I started in 2005.
Yeah.
And I remember what happened here and there. And now that I'm working full time in the emergency room, it is most of my day. Most of my day is managing some chronic care issue. And, there's just no capacity. I used to spend a lot of time trying to help people follow up and figure out and educate like a primary care doctor. So I don't have the time in the ER for that. Like yesterday, all day long, every room was full. It was cold and flu season, the worst time of year in the ER. And so I didn't have time to just give a band to manage the disease processes. So I just give the Band-Aid prescription. And most of these people in this community, because I work in a rural hospital, they'll come back and kind of de facto their primary care. But I feel the obligation to work hard to find a connection for them to go to primary care, if not the clinics. There's usually a clinic or a community health center that you can refer someone to. And I educate them that I cannot prescribe this medicine forever.
And when you bring these issues up to the healthcare leaders in the local area or the hospital administrators, I'm sure that this has been expressed to them. In general, what have their responses been like?
I feel like it's such deaf ears. And That's, they say, what is the thing that burns you up? That's one of the things that burns me up because I see that we're on the precipice of a crisis wherein there's just not enough doctors in general. And then not enough young doctors are choosing primary care, for obvious reasons. And so that's where we need to figure out a way. We need to give doctors more support. We need to keep more doctors in practice. We cannot all quit. It's just not good for society. And so when I speak to administration about that, that's when I speak to them about what I'm passionate about. We need to make sure that doctors have good mental health and make sure that they have coaching and access to various things to keep them healthy mentally and practicing. Connect them back to the why they became a doctor. I think that injecting a sense of purpose and connects you back to the why you became a doctor so you stay fulfilled in your job.
What kind of message do you have for patients? Let's say patients, they're waiting 6 months for a primary care doctor, and they may see they have no recourse and to go to an urgent care or an emergency department just to get basic chronic care services. Do you have any messages for patients in terms of options and tips that they can do?
Well, I do give my patients the spiel that number one, when you do get a good primary care, please let them know. Let them know that you appreciate them and keep your appointments because their time is very valuable. Number two, look around in your community because you have to do some legwork, some hunting to find out who is taking patients within your insurance because especially if you have a serious chronic illness, your health depends on it. And sometimes you may have to travel. Sometimes you may have to go 45 minutes out, even an hour out to be able to get in with the primary care and thinking that if it's only every few months, it's worth it. So being creative in the solution is what I tell the patients.
We're talking to Pamela Buchanan. She's a family physician. Today's Kevin MD article is the ER doctor who became the new PCP. Pamela, as always, let's end with some take home messages that you would like to leave with the Kevin MD audience.
All right. I leave the message that all physicians should take care of themselves. If you're feeling like stressed that you don't want to do this anymore, I advise you to seek out a counselor, therapist, or a coach. I can be reached at drbstrong.com because I'm committed to keeping more physicians in practice in a healthy way.
Pamela, as always, thank you so much for sharing your story time and insight. And thanks again for coming back on the show.
Thank you, Kevin.